Male hypogonadism. It is the failure of testes to produce adequate amount of testosterone, spermatozoa, or both. Klinefelter is the most common cause of congenital cause, and it's thought to occur with an incidence of 2 is to 1,000 live births. Acquired hypogonadism is even more common. So the evaluation of male hypogonadism presentation can be in the form of failure to progress to the puberty, sexual dysfunction, infertility, non-specific symptoms. And the clinical presentation would depend on the age of onset, congenital versus acquired, the severity, uh, complete versus partial, and the duration, functional versus permanent. Secondary hypogonadism. It's a hypogonadism as a result of hypothalamic or pituitary dysfunction. Diagnosis made by the measuring the serum testosterone at 9 a.m. They would be low normal, a low LH and FSH, normal inhibin B and anti-Mullerian hormone AMH. So Coleman Syndrome, it's a genetic disorder caused by the failure of episodic Gnrh secretion plus minus anosmia. It results from the disordered migration of the Gnrh producing neurons into the hypothalamus. The incidence is 1 in 10,000 males, and male to female ratio is 4:1. Diagnosis is made by with the presence of anosmia in 75%. There's increased risk of cleft lip and palate, sensory neural deafness, cerebellar ataxia, and renal agenesis. There would be low testosterone, low LH and FSH level. The rest of the pituitary function would be normal. There would be normal MRI pituitary gland and hypothalamus. However, there would be absent olfactory bulbs as would be seen in the MRI. There would be normalization of pituitary and gonadal function in response to physiological Gnrh replacement. It is most commonly a result of isolated gene mutation. It may be inherited as X-linked, in which CAL1 gene is the most common culprit. Autosomal dominant because of the FGFR1 mutation or CAL2 or a recessive trait. CAL1 gene mutation is responsible for the X-linked Coleman syndrome. It is located on chromosome 22, and it has got a more severe reproductive phenotype. Mutation of the FGFR1 gene, which is located on chromosome 8, is associated with autosomal dominant form of Coleman syndrome. Affected male have an increased likelihood of undescended testes at birth. 12 to 15% incidence of delayed puberty in the families of patients with Coleman syndrome compared with 1% in the general population. Male with autosomal dominant form, that is FGFR1 mutation, would have a 50% transmission to offspring who have increased likelihood of undescended testes at birth. So FGFR1 mutation is associated with undescended testes. The management would be androgen replacement therapy for the puberty induction, and when fertility is desired, testosterone is stopped and exogenous gonadotropins are administered. So apart from the Coleman syndrome, other causes of secondary hypogonadism include idiopathic, among which Coleman is the most common. Other genetic causes include mutation of the Gnrh, Gnrh receptor mutation, GPR5 genes mutation. So Gnrh and GPR5 gene mutation are commonly associated with this condition. IHH, that is idiopathic hypogonadotrophic hypogonadism, fertile eunuch syndrome, and congenital adrenal hypoplasia because of the DAX1 gene mutation. Then it could be related to the functional causes, including excessive exercise, weight changes, anabolic steroids, stress, which could be physical or psychological, systemic illnesses, medication, and recreational drugs. Structurally, this secondary hypogonadism can be secondary to tumors like pituitary adenoma, craniopharyngioma, and germinoma. infiltrative disorders like the sarcoidosis and hemochromatosis, head trauma, and radiotherapy and surgery to the pituitary gland and hypothalamus. Among the miscellaneous causes, hemochromatosis, Prader-Willi syndrome, and Lawrence-Moon-Barrell syndrome are the other causes. IHH, or idiopathic hypogonadotrophic hypogonadism, is the congenital form and is indistinguishable from Coleman syndrome apart from the absence of anosmia. Greater than 90% of the patients are male. Gnrh receptor gene mutation is an uncommon cause of IHH. So this is the gene which can be found in these patients. So Gnrh receptor gene mutation can be present in IHH or Coleman syndrome. Male with acquired IHH may go through the normal puberty and have a normal testicular size, but present with fertility or poor libido and impotency. It may be temporary with normalization of the gonadal function after stopping GnRH or testosterone therapy. Fertile eunuch syndrome, there would be incomplete GnRH deficiency. There would be partial GnRH deficiency, which is enough to maintain the normal spermatogenesis and testicular growth, but insufficient for the adequate virilization. It may require testosterone HCG for fertility. So fertile eunuch syndrome, since the name itself is self-explanatory, there would be less virilization because of the less production of the GnRH. But that's the reason they may require testosterone or HCG for fertility. Congenital adrenal hypoplasia is a rare X-linked or autosomal recessive disease caused by the mutation of the DEX gene, which is located on the X chromosome. It presents with a primary adrenal failure in infancy, and there would be a hypothalamic hypogonadism, which can also be present in these patients. Structurally, usually associated with other pituitary hormone deficiencies. In children, craniopharyngioma are the most common causes. Cranial irradiation for leukemia, a brain tumor, may also result in secondary hypogonadism. The commonest lesion in adults are prorektinomas. Anabolic steroids, cocaine, narcotic drugs may all result in secondary hypogonadism. And all drugs causing hyperproteinemia will also cause hypogonadism. Prader-Willi syndrome is a congenital syndrome which is caused by the loss of imprinted gene on the paternally derived chromosome 15. It should be suspected in infancy in the presence of characteristic facial features like the almond eye, downturned mouth, strabismus, thin upper lip. So starting from above to below, these patients would have almond eyes, strabismus, the mouth is downturned, there would be thin upper lip, severe hypotonia, poor feeding, and developmental delay. The child then develops hyperphagia due to hypothalamic dysfunction, resulting in severe obesity. Other characteristic features include short stature, small hands and feet, hypogonadotrophic hypogonadism, and learning disability. Type 2 diabetes can occur in 15 to 40% of the adults. Lawrence-Moon-Barrell syndrome is a congenital syndrome characterized by the severe obesity, gonadotrophin deficiency, retinal dystrophy, polydactyly, and learning disability, and hemochromatosis. So hemochromatosis can be associated with a number of complications, including central and primary hypogonadism, diabetes mellitus, liver cirrhosis, Addison's disease, and it is diagnosed by genotyping. So hypogonadotrophic hypogonadism. Hypogonadism as a result of gonadotropin deficiency. It is